Back when I was once seeing a patient in the clinic, this patient was brought in by his wife. And his wife said, "Doctor, my husband, he's having some problems hearing me. Every time I ask him to do something, he doesn't do it. And it seems as though he's just ignoring me. I think you need to check out his ears." I sort of came up to him and I did the whisper test with his wife sort of in the far corner. He seemed to pass it. And I did the Tinel's, the Weber test, all of that seemed normal. And so I came up a bit closer and I asked his wife to leave the room. And I whispered, "Is there anything wrong with your hearing? Because I have a very soft voice, so people don't usually hear me, but you seem to hear me well." And he just smiled and looked at me. After that, I knew that it was, his wife came in for a legitimate reason, but he knew what he was doing the whole time. So sometimes you find that in people with dementia as well. They sometimes come to you with someone complaining, "Oh, doctor, my husband's memory or my wife's memory is not the greatest," but there's often another reason. And today I'll be going through that in the talk. Now, essentially, before we start, I thought I'd give a bit of a background information on dementia, and we'll make it a bit of an interactive session. So what is dementia, first of all? So dementia is actually a cognitive disorder. That's a syndrome that's acquired over time. It represents a decline from someone's previous level of cognitive functioning or someone's previous IQ, and it occurs in the setting of a clear level of consciousness, unlike a delirium which occurs in the setting of fluctuating or cloudy level of consciousness. Now, the dementia is defined according to the Diagnostic and Statistical Manual of Mental Disorders. But it's interesting because the latest version of the DSM, the DSM-5, doesn't actually include the term dementia. It actually includes the terms major and minor neurocognitive disorder. Now, the reason for this is that over time, dementia was seen as a disease of older age. It was thought you only got dementia when you got older. But we're seeing a lot of dementia in our younger population, in people who've had traumatic brain injuries as a child, in people who've had HIV. We're seeing dementia in less than 40 sometimes. And so they've changed the term to major neurocognitive disorder to capture all these people as well. Now, the way we diagnose dementia is a cognitive decline that interferes with someone's ability to be independent with self-care. There are 7 domains, and the way I remember these 7 domains is the term 4 aces. So there are 4 aces in a deck of cards, and I use this acronym. So there's 4 A's and then CES. So the first one is amnesia or memory impairment. The second one is aphasia or language impairment. Third is apraxia, which is the inability to follow motor commands. Agnosia, the inability to recognize an object. Then you have executive function, which is planning and judgment. And there are 2 more areas which are included in the DSM-5, not in the 4. This is complex attention, the ability to focus on multiple things at once, and social cognition, your ability to retain and apply information about a social interaction in terms of future interactions as well. Dementia shouldn't be diagnosed when an active delirium is going on and when an active psychiatric illness, such as a psychosis or mania, is going on. The way we classify dementia is also more structured now. So we classify dementia according to whether something's definitive, probable, or possible dementia. Definitive dementia can only be really confirmed on a brain biopsy in terms of the subtype. So often it's classified as probable or possible, and probable dementia fulfills all the DSM-5 criteria. We classify dementia as having or not having behavioral symptoms associated with it. This could be psychosis, anxiety, agitation, or aggression, which we see a lot more in hospitals at the moment. And severity is classified on essentially someone's impact on independence. So whether it's impacting their higher order levels of function, that's their instrumental activities of daily living. I remember that using the acronym SHAFT, so shopping, housekeeping, accounting, food preparation, and transportation. Whether it interferes with someone's basic activities of daily living. I use the acronym DEATH for that. So dressing, eating, ambulating, toileting, and hygiene. Or if someone's fully dependent on their activities and instrumental activities of daily living. That's severe dementia. There's also a couple of scales that we use. So there's the FAST scale, which is the functional assessment tool for Alzheimer's dementia, that classifies people according to stage 1, which is actually normal aging, stage 3, which is mild cognitive impairment, and then stage 4 to 7, which is mild to severe dementia. And there's also the clinical dementia rating scale, which we use for the non-Alzheimer's dementia, and which can be applied on a daily aspect in the clinic. We also have a term called mild cognitive impairment. So mild cognitive impairment isn't dementia, but this is when someone's cognition actually deteriorates from their normal level of functioning, and it doesn't interfere with their independence at home. So if someone had a cognitive decline between 1 to 2 standard deviations less than their normal cognitive function, but they're still able to drive, shop, dress themselves, toilet themselves, essentially we would classify that as mild cognitive impairment. Now, the important thing with this is not every case of mild cognitive impairment develops dementia. There's a lot of people with mild cognitive impairment in the community who actually stay stable, and it doesn't interfere with their independence. So that's why it's important to classify this. It's called mild neurocognitive disorder on the DSM-5. This is just a normal distribution curve of someone's intellectual function or IQ. So you can see that mild cognitive impairment, it's less than 1 to 2 standard deviations from their mean IQ. And when it gets to 2 or more, that's when it becomes suggestive of dementia, but it has to interfere with their level of independence for it to be classified as dementia. Now, there are common types of dementia that I'll be discussing. I guess the most common type that most people know is Alzheimer's dementia, which makes up to 2/3 of dementia in Australia. The second most common type in the older age group is vascular dementia. And that's because as we're getting older, we're getting more people with the metabolic syndrome, with hypertension, diabetes, hypercholesterolemia, and that's predisposing them to vascular dementia later on. The third most common type in the older age is Lewy body dementia, and I'll be discussing this further. And the most common type in a younger onset, so that's less than 50, is frontotemporal dementia. There are also reversible causes of dementia, and that's why it's important sometimes to refer these people who have memory decline to a specialized clinic, either neurology or geriatric clinic. And we look for things such as hypothyroidism, vitamin B12, B6 deficiency, normal pressure hydrocephalus, and some of the younger onset dementias like neurosyphilis and AIDS dementia complex. There are also some irreversible forms of dementia, things like the Parkinson's plus syndromes, Creutzfeldt-Jakob disease. Can anyone tell me what's seen in the image here on the right side? There's a specific type of dementia associated with this. So you can see essentially that there's hyperintensities in the temporal lobe, so these white stripes in the temporal lobe on the brain. This is actually a form of dementia called CADASIL, or cerebral autosomal dominant arteriopathy with subcortical infarcts and leukoencephalopathy. So it's an autosomal dominant inherited disease. So people with this type of dementia have a family history, and it follows a vascular cognitive impairment sort of pattern. We'll be talking about this a bit later. Dementia can follow 2 different types. There's cortical dementia and subcortical dementia. So cortical dementia is when your gray matter is predominantly involved. Affects your memory centers, your language centers in the brain. This is your typical Alzheimer's and frontotemporal dementia. There's also subcortical dementia. Subcortical dementia is when the white matter in your brain is involved, and this can be vascular dementia. It can be things like the Parkinson's plus dementias and Lewy body dementia. And it's important to differentiate because they present differently. So subcortical dementias might have mental slowing. So they have something called bradyphrenia, where their partner reports that they're a bit slower in their thinking than normal. They might have difficulty with attention, and especially complex attention, attending to more than one task at once. And they might have impaired visual spatial skills. So those are some of the key features in that type of dementia. We'll just start off by talking about a bit of functional anatomy, and then we'll go into the different dementia subtypes. So essentially, there are 3 centers in your brain which are responsible for memory. The first one is in your dorsolateral prefrontal cortex, which deals with working memory. So all of you, when you were studying for your physician exams or GP exams or surgical exams, you would have used this center of memory, because just before you went in for your exam, I can take any bet that you've been reading your textbooks and you remembered it just in time for the exam, but as soon as the exam finished, you forgot. That's where your dorsolateral prefrontal cortex comes. It remembers it for seconds and minutes, and suddenly you lose it. Now, once the memory gets stored, it goes into the hippocampus of the brain. And the hippocampus is in your temporal lobe, and it's responsible for episodic memory. So it's responsible for events that happen during your life. And these can be new events, so events that are happening right now, or previous events, retrograde events. And essentially the reason for that importance is anterograde memory, which deals with new memory, is the first thing that's affected in Alzheimer's dementia. Retrograde memory, which deals with previous events, is not often affected early in Alzheimer's dementia, but can be affected later. But if you have an alcohol-related dementia, like Korsakoff's dementia, this is affected as well early on. So essentially, Alzheimer's is anterograde memory. Retrograde memory, if it's affected early on, can be Korsakoff's or alcohol-related dementia. The other center of memory is your anterior temporal lobe, and this deals with facts, so semantic memory. This part of the brain, which is a bit wider than just your hippocampus, is important in frontotemporal dementia, and I'll talk about that a bit later as well. We also have the functional centers that deal with language. So we have Broca's area, which is to deal with language expression. That's in the frontal lobe of your brain. We have Wernicke's area, which is close to the temporal parietal region, and this deals with language reception. And you can see that Wernicke's area in yellow is very close to the primary auditory cortex, which is in the temporal lobe of the brain. So that's where that communication follows. Now, we'll be talking about this, but if you have damage in Broca's area, you have an expressive dysphagia. But if you have damage in Wernicke's area in the temporal parietal region, you'll have a receptive aphasia. So you can't understand what they're saying, but you might sound fluent in what you're saying. We also have the frontal lobe, which is responsible for frontoexecutive function. So this can be responsible for planning, judgment, problem solving. Or I once had a gentleman who came in with frontotemporal dementia who the wife said he was essentially behaving very inappropriately. He was falling asleep when someone was basically pouring out their heart to him and in tears, and he was stripping in front of other friends in the home. So this is a type of dementia that can affect the frontal lobe of the brain. There's also the Center for Praxis, that's motor coordination, and this affects both the motor and sensory cortices of the brain. So you have your primary motor cortex, which is in the frontal lobe, and your primary sensory cortex, which is in the parietal lobe, just behind in green. And you also have your supplementary and premotor areas. So all four of these areas communicate with each other to help you coordinate movement in the body. And this can have an impact on praxis when you're dealing with dementia, in particular Alzheimer's and the gray matter dementias. The final lobe is the visuospatial cortex, and this is the occipital cortex at the back of the brain. There are two streams. The first stream is identifying where an object is in space, and to identify where something is in space, you use your parietal lobe. So that's why you go from occipital to parietal lobe, the dorsal stream of the brain. And then you have your ventral stream, which goes, what is the object? So if you put an object in your hand, to identify what it is, you would have to look at it, feel it, touch it, smell it, and that uses the ventral stream, which communicates from the occipital lobe to your memory centers, the temporal lobe of the brain. So that's, those are the two visual streams. Any questions at all? Now we'll go through some examples. So when someone comes in to see me in the clinic, and they come in with problems with memory or cognition, what do you generally do? You get a bit of a background history. You get their name, their age, their previous occupation, their education level, because all of this matters. It not only defines the person, but it also defines what changes have been present that could signify whether something's abnormal or normal. We also get a history from the patient and the family. The reason we get it from the patient is we also want to know what their insight is. Do they actually understand that they're losing memory or not? And we look at their medications. Some people might have over-the-counter medications like antihistamines, which can have an impact on memory, and it's important to get this, and also herbal medications as well, like John's wort and things might be used for managing cognition too. We get the family history, and the reason that's important is because there are certain younger onset dementias, or the pre-senile Alzheimer's dementia, or frontotemporal dementia, where there's an inherited pattern in them. And we look at physical signs, in particular neurological signs, and do a cognitive test to find out which part of the cognitive domains are affected. These are some of the domains that we look at. One of the things that we do is look at odd beliefs, someone's insight level, and changes in personality and mood apart from memory and cognition. And we look at their activities of daily living and instrumental activities to see what their level of independence that's being impacted during the dementia process. So just a quick recap on some cognitive assessment tools. This is a mini mental state exam invented in 1975. It's the first cognitive assessment tool that was recognized. It takes about 15 to 20 minutes to do. It's the standard tool because it's used to see whether someone qualifies for cholinesterase inhibitor therapy. That's the therapy we use for Alzheimer's dementia if someone's having memory problems. But the problem is if you have a non-Alzheimer's dementia, often that can be missed. And the cutoff score is 24. But a lot of people who have like vascular dementia, frontotemporal dementia may actually score well on this test. And that's why we use some of the other tests. The RUDAS, the Roland Universal Dementia Scale, was invented in Australia in Liverpool Hospital. It's out of 30 as well, and a score less than 23 is abnormal. It takes less time to do than the mini-mental. It takes about half the time. So if you're really stretched for time and you really need to do something quickly, you can do the RUDAS quickly at the bedside. And it's good for non-English speaking patients and patients with a low education level. So people who have less than a year 12 level of education, I often do the RUDAS on because it captures a bit more. The MOCA, or the Montreal Cognitive Assessment, consists of 8 components. It's also out of 30. and a score less than 26 is abnormal. It's useful if you're looking for mild cognitive impairment. That's something that doesn't qualify for dementia, but that's something where the memory is slightly abnormal than for normal aging. And essentially, it can also be used for frontotemporal and Parkinson's type dementia as well. The Addenbrooke's is what we use in the clinic. This is a very extensive test. This takes about 30 minutes to do on a good day. It's out of 100, and basically any score less than 88 is abnormal, but it goes through both anterograde, retrograde memory, various parts of language. It's a very detailed test to see what type of dementia specifically that person's pattern is fitting. Now, we might just go through a couple of essentially flowcharts, and I read an article which really helped solidify some of this, so I thought I might just present this as well. So if someone came in with a primary complaint of amnesia or memory problem, that's affecting their episodic memory, their ability to remember events that's happened over time. The first thing we do, apart from getting a history exam, and if their exam is normal, so they have a normal neurological exam, we do an MRI brain. And on the MRI brain, if there's atrophy in the hippocampus or mesiotemporal area, this is likely significant with Alzheimer's dementia. Now, if the MRI brain didn't show anything, so this is the picture on the far left of the screen, so Alzheimer's dementia here. So you can see global atrophy, and in particular, you can see atrophy just in these hippocampal areas, just at the bottom half of the screen. Actually, I might just get the pointer. So just over here, so the hippocampus, you can see there's a bit of atrophy there. The second type of dementia is Wernicke's-Korsakoff. So if there are memory centers, if there's abnormal memories, but their temporal regions are actually not atrophied, and they have a history of malnutrition or alcohol, do an MRI brain, and you can see essentially a hyperintense area in the mammillary bodies and the periaqueductal gray and colliculi. So this is significant for Wernicke's and Korsakoff. So when you have Korsakoff's dementia, you can get this being highlighted. Mesiotemporal lobe epilepsy is when you have essentially seizures that can contribute to dementia, and you can see this mesiotemporal lobe sclerosis. So I don't have an image here, but you see essentially increased white densities in the temporal lobe of the brain. And then you have limbic encephalitis. This is a more rapidly progressing dementia. This can occur over days or weeks, and essentially you can see periodic lateral epileptiform activity on the EEG, and you also see an increased flare in the temporal horns of the brain, just in that white matter area here. If their predominant symptom is due to a language impairment, and essentially they have difficulty with reception or expression of their language, then we go through the pattern here. So if there's difficulty with articulation, so they can understand what you're saying, so their comprehension is good, but their words sound slurred or they're not able to express themselves properly, this is likely due to a progressive non-fluent aphasia. And this is a type of frontotemporal dementia. And in this type, you see basically atrophy at the insula, just in the frontal cortex of the brain here. It's very, sorry, you might have to use the eye of faith, but it's just over here. So there's more atrophy here. If you have a look at the lateral ventricle, it's slightly more enlarged on the left than the right. The reason is because that insula is a bit more atrophied there. Then you have semantic dementia. So semantic dementia is when you have essentially a fluent aphasia, so you can actually understand what they're saying. They sound very fluent, but when you listen to the content, it doesn't make sense. So for example, they'll substitute words like they'll substitute knife for fork. They might substitute essentially things like roof for house, so they won't fully make sense, but they sound very fluent. So this causes essentially atrophy of the whole temporal lobe of the brain. So you can see big shrinkage here in the temporal side of the brain. That's not evident on the right side. Logophonic aphasia is another type where they lose the ability to repeat your words, and essentially single word repetition and naming is impaired. This causes atrophy in this perisylvian fissure just over here. So that's if they have problems with language at the predominant issue. If there's issues with visual spatial perception, if they're driving into objects, they're getting lost all the time, if their visual spatial skills are impaired, you ask them, do they have any visual hallucinations? And do they have any signs of Parkinsonism? Are they having falls repeatedly? Do they have a tremor? Are they having rigidity, difficulty combing their hair and things? If there's visual hallucinations and there's signs of Parkinsonism, think about Lewy body dementia. Now, Lewy body dementia will look exactly the same on an MRI brain. However, over the last 5 years, we've actually had PBS approval for SPECT scanning. And with SPECT scanning, we can actually see that there's a difference in pattern on Lewy body dementia where the occipital lobe is spared, and there's essentially a reduced uptake in that basal ganglia region. So we can actually have a look at that on SPECT scanning. The importance of Lewy body dementia is it's hyper-responsive to antipsychotics. So if you give antipsychotic therapy, it can actually make the symptoms worse, and that can actually lead to death as well. So that's Lewy body dementia. If they essentially have posterior cortical atrophy, that's where they don't have visual hallucinations, they don't have Parkinson's. This can be another form of Alzheimer's, where the posterior part of the brain is atrophied. This is an image of that here. So you can see there's basically shrinkage in the occipital lobe. And if they do have signs of Parkinsonism, without too much of the visual hallucinations, this can be due to cortical basal syndrome. This presents with dystonia, the alien limb phenomenon, where they don't recognize that their arm is their arm. And essentially, they get clinical asymmetry on the MRI scan of the brain. So the left side might be more hypertrophy than the right, essentially. This is a bit of a complex slide. I might simplify this. So essentially, if you have problems with your attention and executive function, I'll be sending out the slides as well, so don't worry. But if you have problems with your attention and executive function, and you have cerebrovascular history, so if you had a previous stroke or TIA recently, if you basically had any signs of vascular risk factors like hypertension, diabetes, and it's a stepwise progress. So if you don't have a gradual decrease in memory, but you have a sudden decrease and then plateau and a sudden decrease again, think about vascular dementia. And you get an MRI scan of the brain, and you look at the MRI for specific target areas. These are usually the thalamus, the genu of the corpus callosum, and essentially the cingulate gyrus. So these are the common areas that are affected with vascular dementia to cause problems with attention and executive function. So this is one on the left. Codicil, so if you have a family history of migraines, strokes, and you have this small vessel disease in the brain with hyperintensities in the temporal lobes, think about codicil, which is an inherited form of dementia. Things like vasculitis will present with headaches, more rapid onset. Things like the behavioral onset of frontotemporal dementia, where their attention and executive impairment is prominent, but they also are behaving inappropriately, and they have atrophy in the frontal and temporal regions of the brain. Essentially, if you have someone with early falls, problems with swallowing, and problems with looking down at a staircase. So if they're going down a staircase and they're having falls because they can't look down, think about progressive supranuclear palsy. That's because their supranuclear centers in the brain are impaired, so they can't actually look up and down very well. And so that causes what we call hummingbird sign. That's where you can see a small beak in the midbrain because the midbrain is shrinking with this disease. If you have a look, sorry, it's a bit shrunk here, but you can see basically the tip of the hummingbird's beak and then the head just at the midbrain area. So I might just present some cases, and it'll be a bit of an interactive session. So the first one is Mrs. AA. So she's a 75-year-old miner's wife. The history from the patient is so she's aware that she's having problems with her short-term memory. She's now using a diary to remember certain things, and she has a general concept of good past knowledge and facts. But the history from the husband and the family is that she's had a 4-year history in memory decline, especially in new information, new events she's forgetting, like her son's upcoming birthday. She's had no retrograde memory impairment, so she still remembers things from the past, and her language skills and practical skills are preserved. She has no past medical history, and her father developed dementia in his 70s to 80s and died 10 years later. On physical examination, there's no neurological abnormalities. So this is essentially a picture of her MRI brain. We can see, and this is a PET scan down below, the ACE is the Addenbrooke's cognitive assessment, so that's a memory test, and we can see that, So we can see that essentially the memory is significantly affected, fluency is also significantly affected, and visuospatial skills are affected here. We can see atrophy in the hippocampus here, and we can also see the temporal parts of the PET scan are actually impaired in terms of uptake. Can anyone guess what this type of dementia is? Yes, Alzheimer's. Good. Excellent. So that's early Alzheimer's. The other differentials is a depressive pseudodementia and amnestic syndrome as well. So Alzheimer's was discovered by Alois Alzheimer back in 1906. His first case, Augustus D, was a 51-year-old female with amnesia, aphasia, and hallucinations. Essentially, there's a pre-senile form that's an early onset dementia that occurs before the age of 65. And if they come in presenting before the age of 65, you test them for genetic mutations like presenilin 1 and 2 and ApoE4. Essentially, it's a gradual onset dementia that affects memory, so it causes amnesia, word finding difficulty, and visuospatial skills. And it's characterized by amyloid plaques in the brain that start off in the transentorhinal cortex, which is essentially in the hippocampus over here, and it spreads to the whole cortical area. So that's what happens over time. You see medial temporal lobe atrophy in the brain, and essentially there are some special tests that are done. Sometimes people do lumbar punctures, but in reality it's not necessary. If you do a lumbar puncture, what you'll see is a decrease in beta amyloid, and you'll see a raised tau, because the beta amyloid gets sucked from the cerebral spinal fluid into the brain tissue. Treatment is usually with cholinesterase inhibitor therapy, and we usually monitor for an increment or a stable MMSE when we start them on that. Cholinesterase inhibitor therapy is a medication that we give to increase someone's acetylcholine in the brain. When someone's neurons or nerve cells start to die, they lose acetylcholine, and as a result, we give excess acetylcholine to actually keep the neurons that are alive, give them a bit of a boost, and in a third of people, this actually improves their memory. It doesn't reverse their dementia, but it improves their memory to help them function a bit more independently. Once they get to moderate level dementia, that's usually an MMSE of 10 to 14, we use memantine. Memantine is a glutamate receptor antagonist, or an NMDA glutamate receptor antagonist. The way it works is when a neuron dies in the brain, it releases glutamate, which is toxic to the nerves surrounding it. We give a glutamate receptor antagonist to block the glutamate receptor so the surrounding nerves don't die from the nerve cell that has died next door. If they have behavioral symptoms like psychosis, aggression from paranoia, we might give them an antipsychotic, but the important thing is to warn the person responsible and the patient about the risks of side effects, including Parkinsonism, a sudden cardiac arrest, which is about 2 in 100 risk, as well as essentially heart attacks and strokes. So this is a list of the older treatments for dementia. So we had donepezil or Aricept, galantamine and rivastigmine, which are all the cholinesterase inhibitors. We had memantine, which is the glutamate antagonist, and there's also a combination pill of memantine and donepezil, which is available in the States, not available in Australia, but some people prescribe both together. The main side effects from cholinesterase inhibitors is because it increases your acetylcholine, it can cause your heart to slow down, so it can cause bradycardia, it can cause diarrhea, and it can also cause nightmares as well. So it's something we warn our patients about. With memantine, it can cause headaches, hypertension, constipation, but it also reduces your seizure threshold. So if someone's a high risk of seizures, you try and avoid that. And the combination causes a combination of the two. This is one of the newer medications that's come out for early Alzheimer's, lecanemab. This is an antibody infusion against beta amyloid. Essentially, it costs tens of thousands of dollars for each infusion, and it essentially is given regularly every week, week to 2 weeks, or every month. And what they've found is that in the studies in the New England Journal of Medicine, there has been an improvement in cognitive impairment and an improvement in someone's activities of daily living, their ability to care for themselves. But if you actually look at the fine data, the cognitive impairment improvement is very mild. So it's 1.44 on the ADAS-Cog, which is very minimal improvement, and essentially an improvement in 2 on the ADC ADL score, which is very minor. So even though there is a statistically significant improvement, the clinically significant improvement is not really seen in this. The main side effect of lecanemab, or Leqembi, as it's called, is ARIA, which is amyloid-related imaging abnormalities. This can be swelling or edema in the brain, and this can be hemorrhage or bleeding in the brain, which is very life-threatening, and essentially it's something to be aware of. There was another amyloid receptor antibody that was approved called aducanumab, or Aduhelm, that was approved in the States. It's actually being disapproved in November this year because of the risks of its side effects. So it's something to watch out for. It's something personally I wouldn't give to my patients yet until I have more information, because there are risks of side effects, but there is data to suggest it's statistically significant. The other new medications is brexpiprazole. So brexpiprazole was a treatment for schizophrenia back in the old days, but it's now been approved for Alzheimer's dementia as per the FDA for essentially behavioral symptoms, including aggression. The only problem is there's a high risk of death with this particular drug. So it's not currently approved in Australia, but it might be getting there. And suvorexant is basically a medication for insomnia that essentially has been approved for mild to moderate Alzheimer's dementia. It can cause impairment in alertness and can cause suicidal thinking as well. So there are some side effects here again, but these are some of the newer treatments out for Alzheimer's. Any questions at all, sorry? Okay, cool. Next case is Mr. BB. So this is a 62-year-old self-employed accountant. When you take a history from him, he's unaware of why he's in the clinic. He thinks he's completely normal and his wife is being overly worrying. His wife says there's been a 2-year history in progressive changes in his personality. He has impaired judgment. He's getting things wrong on the tax, and every time the tax man is coming behind his back. He's having mood swings, getting verbally aggressive with his wife. There's been changes in personality, and his wife, who has chronic rheumatoid arthritis, is very upset that he's not being empathetic towards her, being very callous, and he's making inappropriate jokes in front of others often, which is not typical for him. Past medical history, he's not had any previous past medical history documented and no issues with excess alcohol at all. And his mother developed dementia early in her 50s, which is an important feature to note about this type. When you examine him, he doesn't actually have any focal disorders. His sense of smell is preserved. And looking at the optic discs, it's actually normal. There's no signs of papilledema. So the reason that's important is there's no signs of raised intracranial pressure. But you can see that he has positive frontal release signs. When you essentially do the palmomental test, you can see it's abnormal. The grip test, he doesn't let go of your arms, so he's abnormal there. And essentially, this is his MRI and this is his cognitive test. You can see on the cognitive test, he's had poor scores in fluency. Language, interestingly, is preserved here. And there's minor impairment in memory. So the memory is 23 out of 26, which is very minimal, but his fluency is 2 out of 14, which is very low. And his total score is 81. It should be 88 and above on the Addenbrooke's test, and his mini mental score is 29, which is normal. But what we can see here on his MRI scan is that there's a lot of atrophy here in the frontal part of the brain, and on the PET scan you can see bifrontal hypoperfusion. Can anyone guess what this type of dementia is? Yes, excellent. So frontotemporal dementia. So essentially this is called Pick's disease, so this is the behavioral variant of frontotemporal dementia, and this is where their behavior might be inappropriate, but their language is actually preserved. The other differential for this is a basal ganglia degenerative disease, Huntington's, and a subfrontal meningioma. So this was actually discovered by a colleague of Alois Alzheimer's. So this was Arnold Pick, and he discovered this type of dementia in 1892. Both of them were working in the same lab together. But this type of dementia is associated with changes in language and personality. It's associated with an accumulation of another type of protein called tau, not amyloid in the brain. And its age of onset is much younger. It's the most common type of younger onset dementia occurring in the 40s to 60s. There's 3 types of frontotemporal dementia. The behavioral variant, where they might have a decline in their grooming, personal hygiene, mental rigidity. They might be perseverating in their behavior. The language variant, which deals with fluent and affluent aphasia, the semantic and the essentially the non-fluent aphasia. And the physical signs on exam is the primitive grasp reflex, incontinence, a history of falls. They're also a bit more hypersensitive to the neuroleptics than other types of dementia, apart from Lewy body. So these are the 3 different types of frontotemporal dementia. And essentially, this is just images of the 3. So the behavioral variant is basically frontal and temporal atrophy. The semantic, you can see that atrophy is greater on the left temporal lobe compared to the right. And in the non-fluent aphasia, where their speech doesn't make sense, but they understand what you're saying, this causes essentially atrophy in the frontal lobe, in the insular region of the frontal lobe of the brain. So management of frontotemporal dementia. So Alzheimer's is associated with an anticholine or an acetylcholine deficiency. So in Alzheimer's, you give acetylcholinesterase inhibitors to increase your acetylcholine in the brain. Frontotemporal dementia is associated with a serotonin deficiency. So often they might have signs of the low mood. So you give them a selective serotonin receptor inhibitor, essentially things like citalopram, escitalopram, which will be useful, or sertraline. And they also might have symptoms of frontal impairment. So there might be verbal outbursts, physical aggression, disinhibition. This type of dementia is more hypersensitive to the neuroleptics, but the ones that are commonly used, quetiapine, olanzapine, risperidone, have been used in the past, but just to be aware. If they also might have Kluver-Bucci syndrome, which is where they might be having changes in their appetite, and they might be eating anything and everything, including soil, things that are not edible. The treatment for this is usually valproate or carbamazepine. Unfortunately, nothing has changed recently in the last couple of years with frontotemporal dementia, but there's a lot of research being done to find out ways of mitigating it. Then we have Mr. BZ, or how am I going for time as well, sorry?
Just around the time now.
Okay. I might.
5 minutes and we'll take questions.
5 minutes? Okay. I might just skip this one, sorry. In terms of, so we have Mr. VD. So Mr. VD is an 80-year-old retired storeman. He's unaware with any problems in his cognition and memory, but essentially a couple of weeks ago, he had a full subdural hemorrhage, and it was managed conservatively. He's had a sudden change in personality since. He's had more labile emotions. He's crying at times. When he's upset, he's more aggressive and having urinary incontinence. He has a background of diabetes, hypertension, and cholesterol. On examination, essentially, he has some right hemiparesis, which is residual from following his subdural, and he has increased deep tendon reflexes on the right. This is the cognitive test, so you can see essentially impairments in his visuospatial skills, his language skills, and his fluency, and also orientation and attention is significantly impaired. So you can see on the MRI scan of the brain, there's a lot of white matter disease, so a lot of white matter small vessel disease, and this is basically vascular dementia. So vascular dementia was discovered by Otto Binswanger. Also, he was in that same lab with Alois Alzheimer and Arnold Pick, but he discovered it in 1894. Basically, it's a stepwise cognitive impairment that occurs over time. Generally, it follows less than 3 months following a stroke. So if it's less than 3 months, you can classify it as a vascular dementia. More than 3 months, essentially, it's not related to the stroke directly, but could be due to vascular risk factors. It occurs with early gait disturbance. That's one of the key features in the history. Frequent unprovoked falls, incontinence in urine, and it shows focal neurological signs on exam. Targeted areas, as mentioned, include the thalamus, basal ganglia, and the caudate nucleus, and the genu of the internal capsule of the brain. And we search for an underlying cause, whether it be AF, hypertension, strokes. This is the Fazekas scale for white matter disease or vascular dementia. So a score of 1 at the top is minor vascular disease, and a score of 3, where the white punctate nuclei are starting to become confluent, is severe disease. In terms of newer therapies, essentially, normally for vascular dementia, we try and mitigate their risk factors, so treat their hypertension, their diabetes, cholesterol. We search for an underlying cause of a stroke, like atrial fibrillation. If they do have a cardioembolic stroke, we put them on anticoagulation. If they do have a stroke, we put them on antiplatelet therapy. If they do have small vessel disease without a stroke, there's been no evidence to suggest that antiplatelet therapy or anticoagulation affects the progression of their dementia. So that was from the Canadian Conference on Diagnosis and Treatment of Dementia. If they have concomitant Alzheimer's dementia, that's when they put them on cholinesterase inhibitors and memantine. In terms of other treatments in other countries, in parts of Asia and Europe, they're using a medication called atovegin, which is actually a deproteinized derivative of calf blood, which is given as a tablet, and it's used essentially for stroke, post-stroke cognitive impairment and vascular dementia. There's been a single randomized controlled trial which has shown benefit in this. There haven't been too many side effects, but unfortunately it was a small study, 250 people, and we're waiting for more studies to come out to see whether there's any benefit, so just watch this space. Other treatments that have been tried but not proven, calcium channel blockers like nimodipine, pentoxifylline, and nicogoline, which increase blood flow in the brain, have been tried but not been shown to be beneficial. So Frederick Louis is the last person. He was not in the group of 3, so he was the only one who essentially didn't join the others, but he's essentially a neurologist who migrated from Poland during the time of the war, and he came and lived in the US, and he discovered the first Lewy body. This was discovered in 1912, which is an alpha-synuclein body. The alpha-synuclein Lewy body in the substantia nigra in your medulla actually causes Parkinson's disease, but when it gets into the cerebral cortex, it causes Lewy body dementia. Essentially, the symptoms that support this, they might have a fluctuating cognition, so they might be sleeping during the daytime a lot, awake at night, and this occurs for months to years, not delirium, which is days or weeks. They might have a REM sleep disorder, so they might become aggressive in the night, so their bed partner will often say, they're kicking me at night and yelling out, essentially, and they're sensitive to the neuroleptics, so avoid things like risperidone or haloperidol in this type of dementia because it can make things worse and it can cause death. The SPECT scan, which has recently been PBS approved, will show signs of this. So it basically shows disproportionately low occipital changes, and the MRI can be indistinguishable from Alzheimer's. Recent advances essentially is the approval of SPECT scanning to screen for this in Australia. The iodine 123 MIBI scan is also used. So essentially this is a scan that's used on the heart. And what we find in this type of dementia is there's denervation in the myocardium, which is associated with Lewy body dementia. That's not seen in Alzheimer's. So this is another screening test. And essentially we do sleep studies and EEGs, which are also looking for other types of dementia with workup of this. Management is essentially cholinesterase inhibitors, so rivastigmine and donepezil are effective. Rivastigmine patches are available. If they have Parkinsonism, while some people start them on levodopa, I tend to avoid that because it can worsen hallucinations. Zonisamide has been approved for essentially Parkinsonism as well, and it's adjusted to levodopa. Once again, it depends on the severity. If it's a mild degree, you might start it. More severe, you would avoid it. And neuropsychiatric symptoms, avoid things like risperidone and haloperidol. If you're desperate and have to use something, use quetiapine, and clozapine can be used, but needs a psychiatry approval. With REM sleep disorders, you manage it with melatonin if you can. If you can't and it's resistant, then use clonazepam. But beware, it increases your risk of falls. So just wait, there's more, the last slide. So essentially, there's a new type of dementia that was discovered in just the last 4 years. So this is the late dementia, or limbic predominant age-related TDP-43 encephalopathy. So this is the newest form of dementia that's out there. Now, the only way you can actually diagnose this is on a brain autopsy. So you won't be diagnosing this in your clinic. You'll be I guess you'll have the pathologist diagnosing this, but this typically presents in people above the age of 80. It predominantly involves memory, so it's very similar to Alzheimer's, but it has a slower rate of cognitive decline than Alzheimer's. It affects someone's thinking, social skills, and it can cause essentially similar symptoms to Alzheimer's, but it causes a buildup of TDP-43, which is a completely different protein to Alzheimer's in the brain. And on the MRI scan, you might see temporal atrophy, but also temporal sclerosis, which is not seen in Alzheimer's disease. Essentially, there's no effective treatment, but it's identified by the World Health Organization, which basically suggests having a healthy diet, exercising, reducing alcohol. At the moment, watch this space because this is a new type of dementia that's out on the market, and you'll see more, I guess, diagnoses and investigation for this in the future. Thank you.